pruritus, all the data that we have is that pruritus in cholestatic liver diseases like PBC is actually far more common than most clinicians realize. The studies show anywhere from like 50 to 80% of patients are affected by itching. And if you ask physicians how often it happens, usually the numbers are a lot lower, probably because we under-recognize it. But it is quite common, and the burden is also more severe than what we traditionally think. And I say that based upon data. Where patients will rate their own pruritus, and then the clinician will rate the pruritus, and the clinician almost always underestimates what the patient says. And it is often not just a matter of severity for the patient, but it's how it impacts their quality of life. And the pruritus in PBC has a huge impact on quality of life. It interferes with sleep, so they're exhausted, they're tired anyway from the disease, and this makes them more exhausted. It can be relentless and very difficult to manage, and so that leads to anxiety and depression, and all of those things make everything worse. And it can result in not only inability to carry out whatever social activities you want to do, but missed days at work. And it's a really pervasive impact on quality of life is what our studies have shown. So urso and obeticholic acid are traditional therapies to treat the disease, but they don't help the itch at all. The ursodiol doesn't help the itching at all. As a matter of fact, there's a phenomenon when you first start it that itching can actually get a little bit worse, and then it kind of comes back down to its baseline, but it doesn't get better. And obeticholic acid, its major potential side effect is itching. So again, it can make it worse. So our traditional therapies for the disease don't help the itch at all and may in fact make it worse. So we have to look towards additional therapies that are specifically directed at the itch. And you know, there's a whole host of what we call traditional therapies, or things that are recommended in our professional guidelines. The reason there's so many is because none of them are, you know, universally efficacious. So those would include things like bile acid binding resins, rifampin, sertraline, naloxone. These are all medications that can be used, and in some patients are quite effective, but in some patients don't work. So this is a really exciting time. We have just had 2 new drugs approved in the US by the FDA for second-line treatment of PBC, elafibranor and seladelpar. And both of those medications seem to have a beneficial effect on the pruritus as well. It can result in several point, maybe 2 to 4 point improvement in itching on a 10-point scale. And so for some patients that may be enough. You know, that may be enough to treat the underlying disease as well as the itching. There are also drugs that are specifically targeted at treating the itch, particularly the ileal bile acid uptake inhibitors or IBAT inhibitors. Those are not yet FDA approved for the treatment of pruritus in PBC and PSC in adults, but they're getting very close. They're in their phase 3 trials, and I think that we'll get those results hopefully soon. There are other drugs that are in the same class, other IBAT inhibitors, which are FDA approved for use in children, for children who have cholestatic diseases that itch, like PFIC and Alagills. And if you're willing to put in the work, you can sometimes get those for adults as well. But it takes a little bit of work because they're not specifically dosed for adults, nor are adult insurance companies used to dealing with those. I would say the most important thing is the assessment. So patients say that we are terrible. Universally, when we talk to patient support groups, they say that doctors are terrible at asking about itching and understanding how bad it is. And so our assessment as clinicians needs to get better. We need to make sure we're asking patients about it, and also not just binary yes, no, do you have itching, but how is it affecting your quality of life? How bad is it? Is this something you want to take medication for? If you are willing to take medication, is this something you're willing to take medication for every day, or you only want to take intermittently, and what side effects are you willing to tolerate? And there needs to be a whole discussion around the itch that happens in their office visits. So that's really a key thing that's not that hard to do, that doesn't require new science, but we need to do better on it. You know, like I said, we are kind of on the verge of getting new therapies, but we don't necessarily have FDA approval for some of these itch-specific therapies. So I still think there's a role for following the guidelines and going with our traditional therapies, bile acid binding resins and rifampin and naloxone and sertraline and things that are in the guidelines. I think if a patient presents with itching and PBC, you need to treat the disease first. So we'll start them on ursodiol, but knowing that that is not going to help their itching if they have severe itching. And it takes, you know, maybe 6 months to a year sometimes to know if that patient is going to respond to ursodiol, is going to even need a second line therapy. For a patient who's itching and miserable, that's too long to wait to start some kind of therapy. So you really need to start some kind of itch-directed therapy in the beginning. It can be any of the ones that are currently guideline approved. And maybe if we have some new drugs in the near future, we can use